Morning, my name is Mary Grosvenor. I'm a registered dietitian and certified diabetes educator at Delta County Memorial Hospital. I've worked here for about 15 years. Provide services to women across the lifespan, from pregnant women through middle-aged, diabetic patients, patients with cancer, all of the services throughout the hospital.
And I'm Brian Eads. I'm a board-certified OB-GYN physician, and I've been in practice over 25 years. And we take care of women after the menopause, adult women, younger women, as well as pregnant patients.
I'm Dorinda Roush. I am a board-certified oncologist and hematologist. I've been in practice for about 15 years.
Well, I think I would probably chime in on women's health care because prevention is key. It's absolutely central. And on the Western Slope, it's not unusual for people only to see their health care provider when they're having a problem. But we can go a long way toward preventing problems in the future, whether it be dietary problems, whether it be oncological, cancer-type problems, by getting patients in on a regular basis to evaluate them for risk factors. Dr. Roush knows that better than anyone.
Yeah, I agree. To me, it means screening and focusing on sort of the entire person. So that would be maintaining a healthy weight, exercise, good diet, kind of reevaluating habits such as smoking, drinking. So just taking care of the whole person.
Mary, what do you think the biggest dietary problems are out here?
Out here in western Colorado?
Yes.
I don't think there's particular to us. I really think they're the national problems. We don't eat a healthy diet in general. Western Colorado is pretty interesting because we have this plethora of fresh, homegrown produce, but do people really eat it? I'm not sure. And that's always top on my list of, where do I start with a healthy diet? More fruits and vegetables. That's a great place to start. Then you look at Western Colorado, we have all of this activity available to us, out skiing, hiking, biking, walking, whatever, but we really don't take care of that. We don't address that. And then that ends up with the biggest problem, which is probably weight. But all of that ties in.
Well, women out here, I've noticed, are aware of the big risks of breast cancer and cholesterol problems and heart disease risks, but they don't really think as much about the risks that loom large. The risk of lung cancer for women. It's always chalked up mainly among the lay press as a man's problem. But we saw a huge spike 10 and 12 years ago in lung cancer in women, and it's starting to come down. But there've got to be other approaches that we take to try and reduce the risk of lung cancer in women.
Right, so I think certainly smoking cessation. I know there are programs here at the hospital. And then there are some new screening guidelines for low-dose CAT scans or CT scans. If you're at increased risk, those have been shown to help improve survival by going through that screening.
What do you think about genetic factors?
Well, I'm sure, so for lung cancer specifically, I'm sure there are some genetic factors there, but we haven't identified those as much as we have for other cancers such as breast cancer and ovarian cancer.
Well, obviously the beginning is when they're pregnant. I always think of women in the traditional role of being providers of health and nutrition to the family, to the community, whatever. But that first time is when we have a baby inside of us. So folic acid is huge in maintaining health during pregnancy and preventing birth defects. But then it's the whole gamut of preventative services, seeing OBGYN early on, eating well, quitting smoking. All of those things tie in early on, and then everything changes as we move through the life cycle.
Now, Mary, I'm hoping to catch people a little bit earlier than when they come in pregnant. Because
they should be taking their folic acid before they're pregnant.
We have a huge issue, not only with middle-aged women, but with younger women here, who become sexually active and who perhaps don't consider their contraceptive options. We like to see young women when they're in high school, and we have the conversation very often they talk to their mother and their father, and as I was when I was in high school, my parents didn't know anything. So it's an opportunity for somebody else to warn them of the risks, talk to them about how to mitigate those risks, and tell them about potential problems and STDs they can be exposed to. And then we move into the pregnancy phase, and then we worry about a whole new range of things after that, don't we, Dr. Roush?
We do, but I would like to back up a little bit. As a mother of a 14, soon to be 15-year-old child, when do you think that they should start? I mean, do you think they need to see a OBGYN or just their primary care physician to have this? Conversation?
We don't do pap smears now until age 21.
Okay.
But I certainly, when somebody is in high school and getting ready to go off to trade school or potentially college, I like to have them come in with their mom, if possible, for a conversation only. And basically it revolves around, none of this may apply to you, but when people are asking you in the dorm, here's the facts you need to keep in mind. And so it's nice to start that relationship so that when they're in college, if they're confronted with some issues they haven't been confronted with before, that they know where to go, they have a resource, they can pick up a phone.
How many people in this county do you think are taking advantage of the HPV vaccine?
Well, not nearly enough.
Okay.
And
all right.
HPV is a virus that can lead to cervical cancer later in life, and some of the worst offenders of that are viruses there's a vaccine for, just like all the others you're vaccinated for before school starts. And so if we can get young people, males and females, to avail themselves of that vaccine, we would see a dramatic decrease in the risk of cancer moving forward.
Right, so you mentioned cervical cancer, head and neck cancer is another one that decreases.
Oral cancer.
I see a big issue with people don't sit at tables and eat dinner anymore, and that's the whole social aspect of how do you learn from your family, how do you learn what to eat. And so that's something I counsel whenever I see little kids. It's always with their families saying, do you sit at a table? Do you sit down and eat together? No, we all go to our bedroom and eat watching TV. Kind of scary. So I think it starts very young. Teen years are tough, as you know, as a mother of a teen.
The average menopause age in this country is about 52, but you'll have people going through the change at 45. And for those who don't know, menopause is just where your ovaries stop working and you go through the change of life, as they call it. Some people don't go through till almost 60. People on the Western Slope are pioneer stuff. They've worked on farms and ranches, they've had kids.
It's a challenging time. And there isn't actually a menopause diet necessarily, but the issues of weight maintenance, stress reduction, we eat in response to stress. Menopause is a stressful time in life. So I think it sort of emphasizes all the things that we should be doing all along. More fruits and vegetables, getting some exercise. Exercise is a great stress reducer. Stress usually increases the junk food we eat, which promotes weight gain, which makes us feel worse about ourselves as we're going through menopause. So it's a big package that kind of encapsulates everything that's going on over the life cycle, but in that moment it becomes even more important. Also, we tend to, as hormones change, it's easier to gain weight. So women tend to gain weight at that period. So diet, exercise are really important at that time.
I'm going to open up a can of worms perhaps, but what is the current thinking on hormone replacement therapy?
Well, hormone replacement therapy is where women have terrible menopausal symptoms, and for decades they were offered hormone therapy. There were some negative side effects, including increased risks of breast cancer and uterine cancer, and so the philosophy was to scale back on the hormone therapy that was given to women. In the past 2 or 3 years, there have been additional studies which indicate that perhaps it's not as dangerous as we thought it was 10 or 15 years ago. So more women under the appropriate circumstances and with proper screening are using estrogen therapy, feeling better, having the ability to maintain their weight better, having more energy, and less menopausal side effects. So that's a good question that a lot of people ask.
Good, and I don't know if it helps with bone health too. I think that's the other thing we need to worry about as we age is maintaining healthy bones, and once again the exercise and proper diet, I'm sure, with calcium and vitamin D. So just aging in and of itself puts you at risk for most other cancers. So breast cancer, just being a woman and aging, having breasts are risk factors. And then again, other bone marrow cancers, just as we age, it's a risk factor.
Well, and there's dramatic new genetic testing that we had before, something called BRCA testing, that really was only indicated and only approved for a very narrow range of people. But now that's broadened dramatically so that many people qualify for genetic testing, do they not?
They do, and that's another risk factor. But that of course doesn't change as you age. As you age, you have more time on Earth to obtain a cancer. But if you're born with that risk, you're born with the risk.
Yeah.
But true. But on the flip side, only about 10% of breast cancers are genetic in origin, so that means we still need to be vigilant about our screening and
Sure.
self-exams.
And what happens if you are identified as high risk? I mean, does that change the screening recommendations?
We send people to Dr. Roush.
okay.
It does change the screening recommendations. So in addition to having mammogram annually, you can consider having an MRI annually as well, so you can alternate the mammogram with MRI. And then the other option, depending, it can be more dramatic, such as prophylactic mastectomy, so having breasts removed before cancer is determined or developed.
Same applies to ovaries. There are people who are at very high risk for ovarian or tubal cancer. And so if they're having another surgery for another reason, it's not a bad idea to lower their risk by removing tubes and ovaries.
Are those genetically identified too?
They can be. Probably not the majority of them, as Dr.
Right.
Roush said, but certainly you can lower people's risk if you know they have a genetic tendency. So these are the kind of issues. You don't know if you're at high risk unless you've kind of gone through the screening process, looked at your family history. So this is something to bring up with your individual physician.
So I know I have a family history of ovarian cancer. I need to come to you and have that conversation.
You do. We need to talk about that and look at who that was and determine the reality, and maybe even sometimes get some medical records.
Interesting.
The other thing so for women who are determined to be at high risk, and not just for breast cancer, high risk for breast cancer, not just because of their genetic background, but because of some other, if they've had prior breast biopsies, if they've started their periods early, there's some other things we go through. There are some medications you can take to reduce your risk of breast cancer as well. We've talked about screening. I just want to mention that the guidelines, and not just for women, but for everyone, for screening for colon cancer have changed. We're finding more and more colon cancers in young folks. So now the recommendation is to think about a screening colonoscopy starting at age 40 or 45.
Oh my heavens.
So I really feel strongly about that. I know it's not pleasant, nobody likes to talk about it, but
So
Yeah.
I see those ads on TV that now I don't have to have a colonoscopy. I can just do this home product. Are those
Cologuard,
effective?
they are. But for people who are at average risk, and then you have to know that if this test is abnormal, you still have to have a colonoscopy, but they're still effective. I would still talk to your doctor about what your risk level is.
Well, and the recommendations actually involve something like a Cologuard or something like a colonoscopy, depending on your risk. But also in between, you're supposed to have annual screening for evidence of blood in your bowels or things like that. And I have not seen a single patient in the last year who probably has adequate colon cancer screening. And so that's something we're going to need to focus on. Redouble our efforts.
Right.